to you, especially in the realm of—
This meeting is being recorded.
In the realm of domestic violence and how the two correlate together. So we do have a lot of information to give you in a short amount of time. So we're just going to get started here. And first, our objectives are that we want you to understand the correlation between domestic violence and non-lethal strangulation. And you have to remember that everything we're going to talk about today it applies to both pregnant and non-pregnant domestic violence victims. So just to keep that in the back of your mind, the signs and symptoms of non-lethal strangulation need to be known because we have both the visible and the non-visible. We need to understand the dangers of minimizing because we don't ever want to discount what these victims are saying to us and telling us that it happened to them. And our case study is going to explain that a little bit more and cement that in. And then I'm going to have Cheryl talk about some new technology that is coming out for non-lethal strangulation injury detection. So that's what we're going to cover this afternoon. Before we get going, though, I have some thoughts for you, or some statements and a question here, and I just want you to put these in the back of your head, look at them. There's 4 statements. They may or may not be true. And there's a question just to see if maybe you do know what the answer to this is. And then at the end, we're going to look at them again, and we're going to go over each of them, and that's actually going to be our discussion at the end. So just keep these in mind as we go. And first, I'm going to start with the case study. And this actually happened at my prior organization in Virginia, where I came from. And I was not the forensic nurse on this. Alicia was. So if I speak about Alicia, that's who I'm talking about, the forensic nurse examiner. You're going to see a link down there at the bottom of the page, the Facebook link. And that is actually a link to the Strangulation Prevention Institute's Facebook page, where this full 20-minute interview with Alicia is on. And it's actually used now in their training that they do all over the country, because it was such a pivotal moment and turning point in the way we practiced at my prior facility. So just to give you a little bit of a background, this female patient presented to the freestanding emergency room. We did have 2 hospitals with emergency departments and a freestanding, and the forensic nurses were mobile, and we went to all 3. So she did present to the freestanding with suicidal ideation. During the nursing assessment, several questions were asked. We started with the safety questions. In the EPIC charting, we were able to go a little bit further, and we always asked, have you ever been choked or strangled? And she said yes. And so that opened up a whole other set of questions that were asked. And by the time the ER nurse got done with her, she actually disclosed that she had been strangled within 24 hours of presenting to the ER. However, she declined law enforcement involvement, and she declined to speak, or not to speak, but to have a forensic exam done. So the ER nurse kind of was at a loss, because she wasn't quite sure what to do. So she went ahead and called Alicia up and said, this is what I have. Do you have any suggestions for me? And Alicia said, I know she doesn't want an exam, but maybe just let me talk to her on the phone. So she got on the phone, and Alicia said immediately she could tell that her voice was very raspy and very hoarse, and something was not right. So she delved a little bit further and asked her, did you lose consciousness? And she said, yes. Did you lose control of your bladder or bowels? And she said, yes. And so that right there triggered Alicia to get on the phone with the ER doc and said, she might not want to see me, but we need to make sure that we're doing our due diligence in terms of getting a CTA of the carotids, which is the gold standard. And the doctor, she said right off the bat, was, I am up to date on all current information, and the soft tissue x-ray of the neck is fine. It's already come back and it's normal, and she's going to be discharged. And Alicia really stood up for this patient and advocated for this patient, where he finally ordered the CTA, the carotids. And she ended up having laryngeal edema, which was a significant find because the other did not show it. And so much so that the radiologist went back to review the soft tissue of the x-ray and said, you know what, it is there, and actually amended his original results. And this was significant in our organization because for years we had been trying to get the doctors to change this and they wouldn't do it. Number one reason was there are no visible injuries, and if there aren't any visible injuries, there's no need to do it. And number two was we don't want to put them through the radiology. But this actually resulted in an immediate change in policy, and now that organization always does a CTA of the carotids on our strangulation victims. Fast forward 2 months after that, we had another close call. It was actually my patient. Same type of thing, same doctor, even though we had the new protocol in place, and this one had a partial right carotid dissection. So it just goes to show that we need to do what the recommendation is because a lot of these injuries are internal. So you'll see why this is so important as we go on. So we're going to start with the South Carolina statistics, which I know that you guys touched on a little bit before, I guess last time. And so just to kind of reiterate, 2018, South Carolina ranked 11th in the country for the number of women killed by men, which is the first time that they were not in the top 10 since all these statistics have been collected. So we just kind of wanted to reiterate that part or that information to you and these other statistics that you see here. The next one is about the domestic violence fatality report. And this is actually the 2020 report, the next slide, and that has from the 2019 fatalities due to domestic violence. And the one thing I want to point out here is on the far right-hand side, you see that 2% of all of those that were murdered at the hands of their intimate partners were done so via strangulation. This is only the group that it actually went past the point of no return, and how many thousands do we have throughout the state that are actually being strangled by their intimate partners. And if we take that a step further and talk about the prevalence of domestic violence in pregnant women, the CDC says between 3 and 9%, 3 to 6%, depending on what studies you're looking at, of pregnant women actually report being assaulted, whether it be physical, psychological, verbal, or sexual violence. But other clinical studies have used more comprehensive measuring tools, which is why we are seeing these higher numbers across the board in all of these categories. And this study was actually done by Holmes and Kim back in 2018, 2019. You can see the significant difference there. So how does all of this relate to the strangulation, the domestic violence go together? Because in domestic violence situations, once the perpetrator starts strangling their partner, it is the leading indicator of the violence and how it escalates. Once that happens, all it takes is one time. And once it happens one time, those victims are 750% more likely to be killed by a gun, the studies have shown, but they are more likely to be killed. Yeah, and it's the perpetrator's way of saying, you know what, I can kill you at any time. I can take you right to that brink of the point of no return, and I can bring you back, and I can take your life at any time. And I hate to use the term better way, but what better way to exert that power and control that we know domestic violence is all about. So that's why it's so important to understand that once the strangulation starts, then that's an indication that the violence for that victim is going to escalate. For those of you who have not been on the Strangulation Prevention Training Institute's website, I strongly urge you to go. You can find resources like this right here, the signs and symptoms. And these are also handouts that I have sent to Rachel for you. But they are a wealth of information. And if you've not had the opportunity to ever sit in on one of their trainings, they are amazing. They're out of San Diego. Excuse me, but you can go into the website, you can go to resources, and you can pick, are you the discipline, are you a lawyer, are you medical, are you a first responder, are you a victim? And you can choose that category and find a whole host of resources for you. So here's one right here that I use quite often in my trainings. You can see it's broken down. You've got your, your visible injuries versus your non-visible. And I like this one because most of your patients are not going to have visible injuries. So you have to look at other things. In Alicia's case, she immediately heard that hoarse, raspy voice on the phone. And she even says in her interview, if you watch that interview, she goes, I've never even met this lady. And I could immediately tell just by talking to her that something was not right. So there's other things you can listen for and look for. Loss of memory. We know that trauma hinders somebody's memory on the other end, and that lack of oxygen just makes that worse. So there's just different things that you can look at. They also have one for pediatrics. That's a really good one. And then they also have a lot of the resources in Spanish if you have a large Spanish speaking population. Other resources you could have, like the next one would be for the doctors, the algorithms. This one is specific to pregnant adult patients. And you can see there at the bottom, it says the CTA, the carotid vertebral arteries, is the gold standard for radiographic evaluation of these patients, these victims. And it does also say there that it is safe at all stages of pregnancy and even for lactating patients. So I put this out there, and if you do have this handout, it's actually 2 pages. The flip side will actually give you all the resources. But here in all the McLeod ERs, we have a forensic binder, and there's actually one section on non-lethal strangulation. And we keep these algorithms and all the resources back there for the doctors, just in case they want to review something, they want to look something up. So they know. And we've done education with our ER doctors, especially here at the Florence ER, and they've been very receptive to this information and understanding why this is very important. So if you do have a patient, I know that you've gone through some screening tools before, but here's a good one for you, just in case you have never seen those. It's safe, it's easy to remember. Do you feel safe? For all DV patients, and actually this should be probably asked of, the safety question should be asked of all patients. But are you afraid or abused? Do your friends and family know? Do you have a support system that can help you? And if so, or even if you do, where are you going to go? Do you have an escape plan? So this is a very easy one to remember to ask your patients. And once you have the basic safe questions down, we have to ask the question of all DV patients. Have you been choked or strangled? 9 times out of 10, they're going to tell you, if somebody says yes, they're going to say they've been choked. We just re-educate them. And what I say is, do you mean somebody put their hands or another object around your neck or your throat and applied pressure? If they say yes, okay, you've been strangled, because legally that is what we need to be charting, is strangled, because they are not the same thing. And then sure enough, they always say choke, but that's okay. And then we're going to go even further, and we're going to ask the 5 basic strangulation questions that are here. And these are just going to help you help identify that this patient might be at higher risk for medical problems days, weeks, or months down the road. And I'm going to turn this over to Cheryl now, because she's going to talk about this new technology that we're starting to look at to help us identify injuries.
There we go. Hopefully I'm unmuted now. Thanks, Dr. Johnson and Campbell and Rachel, for inviting us today. We're excited to be able to talk about some of these things with y'all. And I just wanted to touch on some technology that many of you may not really be all that familiar with. I was not that familiar with that. Does anyone know about medical thermology? Have any of you really delved into that? I had not. And I have done a lot of work and provided a lot of education over the years with one of the instructors at the Criminal Justice Academy. His name is Brian Bennett, and he's been to the Strangulation Training Institute and does tremendous amounts of education around the state on the topic. I mean, he introduced me to the concept of medical thermology. And did anyone know that we actually have an academy of Thermology here, right in Greenville, South Carolina. I mean, I had no idea that was so close to us, but evidently this technology is really not brand new. It's just brand new to this. It's evidently been used in veterinary medicine for many, many years, especially specific to equine injuries with race horses and that type of thing. It's been used in breast imaging and also in dental, oral, and systemic health related complaints. And that's how it can be used in the care of domestic violence patients. The thermal changes that occur, the methodology is that the infrared technology is used by means of a camera, a specially developed camera, to detect the thermal changes that can be indicative of injuries, inflammation, and trauma. And so there were a couple of physicians, one Dr. Smock, not Dr. Spock, but Dr. Smock, police surgeon at Louisville Metro PD, and I think the president of the American Academy of Thermology in Greenville, Dr. Schwartz, got together and thought, well, maybe, you know, there's some use for this in strangulation injuries and domestic violence injuries. And so they've begun to do some research about this, and it's being looked at for use in patients. And I don't want to steer you the wrong way in thinking that this is the way to diagnose it. It is not. The way it was explained to me is that it's just a strong indicator. It's just another tool that someone can use in their toolbox to help better differentiate those injuries. But I don't know if Rachel can go back to that other picture, but pressure, there was a normal, if you go back another one, there's a normal picture. And, you know, to look at her with the naked eye, we don't really see any injuries there. There's no bruising, there's no redness, but with the special camera that was used, it is very obvious that you can see the fingerprints. You can see, I can easily outline 4 fingers, and I would imagine if you looked at the other side, you'd see a thumb, because that appears to be the way the hand was around the neck. There's a lot of training that occurs with the use of this technology, and evidently the way it was pointed out to me is they have the Atlas of Normal Thermology and the Atlas of Abnormal Thermology. So people have to be highly trained in being able to recognize these subtle patterns and changes of color with the use of the camera. But I thought that was a really poignant picture and really well outlined. So I can easily see how someone like a coroner or a forensic department could utilize this type of technology in their toolkit to be able to help potentially see where some injuries have occurred. So I thought it was exciting. I thought it was interesting and sort of cutting edge for this type of work. And I just wanted to share that with you and let you know that those things are out there. I do believe that there's probably more to come with this. Brian is doing a lot of work. He's doing a white paper right now with one of the doctors about this. And our program here is hoping that, you know, we could potentially maybe pilot the use of the thermography to pilot in our program at some point in the future. So possibly more to come, but I just wanted to share that with y'all. I've shared a page full of resources about the Academy in Greenville. They have an introductory video. There's a lot of information out there, and then some of the other papers about strangulation and about thermology and the use of thermography in these injuries. And that will be available to you through Rachel if any of you are interested in just looking at this further.
Thank you so much, Cheryl and Shannon. And just a reminder for some of the things to spark discussion. There is a difference between choke and strangle. If a victim of assault can't give details of what happened to them, they are lying or hiding information. Are these true or false statements? Most strangulation victims will present with visible injuries. If a person can make noise or breathe, they are not really being strangled. What is the recommended radiographical study for non-lethal strangulation victims? We have some myths about strangulation, which we will go back to during the question and answer discussion. Here is the contact information for Cheryl and Shannon, which I will share. In addition, just before we cut to the discussion, I want to remind everyone that on April 20th, Dr. Connie Gill, who is the director of Women's Reproductive Behavioral Health, dealing with all things psychology and psychiatry, will be discussing even a deeper drill into the psychology and psychiatry of this topic. Second.